Good morning, everyone. It's Tuesday morning, afternoon, evening, depending on where you are, and it's Neurology Morning Report. So glad you've all made time to join us to discuss a neurology case this morning. So if someone has a case they would like to present, we'd love to have you present that case, and we'd like two discussants, ideally one identifying as a woman and one identifying as a man, to discuss the case this morning. Do we have any volunteers? Saki, great. Thank you for volunteering. I know you've discussed before, so happy to have you, but we'll see if anyone else wants to discuss who hasn't had a chance. If not, happy to have you. And then anyone else like to discuss with Saki? And does anyone have a case they brought to present, neurology case? Okay, Gabby always has cases because she completed a neurology residency, so she has 1,001 cases at least. So we'll need one more discussant who would like to discuss with Saki. Looks like you're in, Saki. We have no one competing to discuss a neurology case. If you came today thinking, oh no, I didn't know it was Neurology Morning Report, I thought it was internal medicine. Well, welcome, it's Neurology Morning Report. And if you're thinking oh, neurology is my least favorite subject, it's so hard, that's a great reason to discuss. We'll hopefully make it clearer and easier to understand, and you'll get some good practice. Still no takers. You might be thinking, I don't know, my first language isn't English. No problem at all. We have Spanish and Brazilian and French and so many other languages represented here to help you along if need be. Anyone like to discuss with Saki? She's all by herself. Maybe Saki, and you can introduce yourself, and that will inspire others to want to join you. Oops, we just got someone. Great, Hamza, fantastic. Oh, we got two all of a sudden. Can someone hold for, for next Tuesday? Great, we have three potential discussants. Hamza deferring to Sarah. Okay. Leave it to you three. Someone can start introducing themselves. Oh, okay, Saki, why don't you introduce yourself, and Hamza and Sarah will decide who wants to discuss this week, and love to have one of you discuss next week.
Okay, am I audible? Okay, great. Hi, so my name is Sakhi, and I just graduated med school last year. I'm excited to do this. I've done this once before, and yeah, looking forward. But just in case Sarah and Hamza want to go today, because I've already done it before, I'd be happy to give them my spot, but it's totally up to you guys. But I'm excited nevertheless. Thank you.
Great. Thank you. Sarah and or Hamza, did we make a final decision?
Oh, sorry. I'm just gonna speak very quickly. English is not my native language, so it's okay if I have to discuss next week.
No problem. Looks like both you and Hamza are politely deferring to each other. You spoke first, Sarah. We're happy to have you. And don't worry at all. This is meant to be a very open and very global space. And Gabby is here who can help with, if I'm guessing your native language by your name, maybe I'm not guessing it right, but can help out if there's just something you need translation on, no problem. What do you say, Sarah? Would you like to introduce yourself and join us today? And no worries at all. This is meant to, we have so many different languages represented here, and we'll learn some things in the process too.
Oh, okay, sorry. I was having a bit of trouble to start the video. I'm Sarah. I'm from Brazil, and I'm currently studying for step 1. Personally, I didn't get in neurology yet, but I'm trying. So I hope to contribute to something in the case today.
Fantastic. Well, thanks for joining us. Sorry about step one, but good luck with it. And great. So Valeria, maybe you can help us with scribing and with teaching points. And Gabby, if you want to give us the chief concern, we'll go ahead and get started.
Awesome. So the chief concern is facial palsy.
Facial palsy, fantastic. So facial weakness. Sarah, what do you want to get us started? What comes to mind when you hear about facial weakness? That will definitely be on the step in one way or another. And in real life, it's pretty common too.
Yeah, honestly, there's a lot of things that come to mind. Of course, I didn't get to neurology in my studies for step one, but for me, the first thing that comes to mind is I believe, I don't know how it's called in English right now, but it's called AVC in Portuguese. It's when a patient has aneurysma or something in their brain and it just kind of stops for a bit, the circulation, you know what I mean? I'm so sorry, I get so nervous when I'm trying to explain something, but generally if this patient is someone that is in the more elderly, I would think about this. But if it's a child, I would probably think about infections or something like that.
Yeah, great. We understood you perfectly. AVC in many languages, CVA in English, cerebrovascular accident or stroke, right? So when you hear about any weakness, face or otherwise, right? As you said, you could think about a vascular cause of that, like a stroke, right? And then you mentioned another cause of facial weakness could be infections. Was there any particular infection you had in mind?
Right now, I'm in my pediatrics rotation. So actually, there was a patient today that one of the causes was like congenital. In fact, if I'm not mistaken, it was like I don't know if it's something that happens in the United States yet, but it's called syphilis. Is syphilis not syphilis? Cytomegalovirus. I don't know, but it's yeah. So the baby just was born with a part of the face that was with paralysis. So maybe it's not very common, but it's something that can happen.
Okay, yeah. So you saw some children with congenital infections. You mentioned syphilis and CMV. There are many others that, as a result, there can be all kinds of congenital deficits at birth. And I'm not a pediatric neurologist, but I believe you that you saw some with some facial weakness as part of a larger, potentially congenital syndrome. Great start. Sarah, Saki, what's coming to mind for you?
I think the most important for me would be, is it upper motor or lower motor? I think that would be the first thing I would see. And that if you're allowed, and I think we'll figure that out with the exam. And with the complaints of the patients as well, we can even ask them if it's a telemedicine consult or if we cannot really see them. And I think the next thing would be onset, because if it is upper motor and if it is stroke, then time is brain. So got to find out for how long it's been happening, or if it's just something that's long standing and someone told the patient, oh, your face is slightly crooked, and then they get a little. So I think these two things preliminarily would be important for me.
Right. So yeah, when you hear facial palsy, you said you want to figure out if it's upper or lower motor neuron, or as Valeria transcribed it, central versus peripheral. Tell me why that came to mind, and can you explain it a little more to the group?
So with the lower motor neuron facial palsy, it would be more of a peripheral process, whereas with the upper motor neuron, it would be more peripheral and just below the brainstem and below the brainstem. And with the upper motor neuron, it would be above the brainstem. And when it's upper motor, I think, Sarah, when you're studying step 1, you see this face, you see this picture of a face with just the lower part getting affected and the eyebrows working fine. And that's upper motor, because the upper motor neurons innervate bilaterally, whereas the lower motor neurons, they just have unilateral innervation. So when a patient has lower motor neuron palsy, they'll just have the entire face paralyzed. And the reason why it's important, as I said, was, I don't know if I'm getting your question correctly, Aaron, but I think because of the time. And just to know the cause, basically. Lower motor would be infectious causes, viral causes, and upper motor would be anything affecting centrally, I think.
Yeah, perfect. So this is a place where we haven't gotten to the exam yet. And of course, we take the history and then we do the exam. But if we see in our clinic schedule for the day something related to the face, as soon as the patient starts talking, we're looking to see what we can see on the face, even though the exam comes a little bit later. And the reason is, as Saki explained, is that different patterns of facial weakness have very different localization. So the easier one to understand is just the facial palsy. Which cranial nerve, Saki or Sarah, are we talking about here for lower motor neuron?
Sarah, you want to try that?
You know which cranial nerve?
I know it's 7, but I have forgotten the name in English, but I know it's 7.
7, that's the name in English also, the facial nerve, yes, cranial nerve 7, perfect. So if you have a cranial nerve 7 lesion that's complete, you lose innervation to the motor functions of one half of the face. And so all of the functions on the face will be impaired. So the patient won't be able to smile on that side, which is the lower face Saki was telling about. And in the upper face, patient won't be able to close the eye, won't be able to raise the eyebrow, won't be able to wrinkle the forehead. And some people learn this, including me. I learned this backwards somehow in medical school and thought it would cause ptosis. If the face was weak, you would see ptosis. And when I was a neurology resident, I mentioned on rounds, could this be peripheral, but there's no ptosis? And everyone looked at me like I was not making any sense. And ptosis from a 7th nerve palsy. And it's actually interesting. The lid is controlled by the levator palpebrae, which is controlled by 3, and a little bit by the oculosympathetics. But the muscles innervated by 7 is the orbicularis oculi, which is if you're deliberately sort of winking one side, squeezing one side. And when that muscle is weak, the eye will actually be more open on the affected side and won't be blinking. So when you're watching the patient talking to you, it can be a very subtle sign that when they blink, and we all blink time to time, that side doesn't blink, or you might see the eyeball roll up. It's called the Bell phenomenon. So the facial nerve palsy, 7th nerve palsy, the entire side of the face will be weak. It's a more dramatic deficit, but usually, as Saki said, it's actually a little less concerning. If you see a smaller deficit, the patient can't smile on one side, but they can raise their eyebrow, they can close their eyes, their blinking looks okay. That tells you have a problem in the brain. It's a smaller deficit, but it's actually more concerning because we know things in the brain could be a stroke, a tumor, demyelinating plaque, et cetera. Whereas the facial palsy most commonly is just idiopathic benign Bell's palsy, although it can be caused by other things we'll talk about. And so why does this happen? Saki explained this a little bit. The capital W, why did it end up like this? That I don't think anybody knows, but the cranial nerve 7 comes from the pons, from the 7th nerve nucleus. And like most motor functions, right, you would think, oh, well, if I'm talking about the right side of the face, shouldn't it be innervated by the left brain? That's true. But also, for some reason, there's a bilateral input just for the upper face part. Actually all of the cranial nerve motor nuclei get bilateral input. That's why you almost never see jaw deviation in a stroke or something like that, because these are such important functions in the face, throat, that you're getting bilateral input to most of these nuclei. But for some reason, for 7, you get bilateral input for the upper face, but just the unilateral, contralateral input for the lower face. Meaning if you get the 7th nerve, doesn't matter what's happening above it. I always explain it's like if the airport is closed, it doesn't matter, where the flights can go to and from. The 7th nerve is closed, doesn't matter what's flying in, right? But if you have a lesion in the brain, you would have thought, oh, shouldn't I have the whole face being weak? You would have been right, except for some reason there's a backup just to the upper face. So that gets spared. So this is a place where just looking at the patient and examining them, you can be pretty sure that you have a problem either in the brain or upper brainstem above the level of the seventh nerve nucleus. So midbrain is fair game, upper pons, or a lesion in the pons at the level of the seventh nerve nucleus or in the seventh nerve itself, just based on the pattern of weakness in the face. And then each of these have a different differential diagnosis. Brain is anything that can happen in the brain we mentioned. And then seventh nerve palsy, what sorts of things would we be thinking about? We heard about infections, any particular infections? And then other things in your differential for a lower motor neuron, so for a seventh nerve palsy.
I think, as you said, idiopathic is the most common. And after that would be viral infections, which would be anything from HSV, CMV, HIV, Lyme's. Then I would say unilateral or bilateral facial palsy, because there are certain infections that can also cause bilateral facial palsies like Lyme. So it would, but mostly these are the ones that I can think of at the top of my head. Yeah.
Yeah. So a lot of people call any seventh nerve palsy Bell's palsy. Technically, Bell's palsy is when it's idiopathic. Okay. And there's some sense that the idiopathic Bell's palsy may be caused by HSV reactivation, but we don't really know for sure. Depending on where you live, if you're in the northeastern or sort of eastern seaboard of the United States, and it's summer, fall, and a patient has a facial palsy, your differential diagnosis is Lyme, 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 Lyme. Super common. I've had Lyme disease twice. I used to live in the Northeast. I never had a facial palsy, but I had just a systemic illness once, and then I had Lyme arthritis the second time. So it's super common. If you go outside, you get bitten by a tick. But Lyme, HIV, you mentioned, interestingly, facial palsy and HIV is often at the time of seroconversion. I've never seen this, but it's reported that with the flu-like systemic illness around the time of seroconversion, a patient can have unilateral or bilateral facial palsy with or without meningitis. And then other things on the differential, the patient has bifacial weakness, particularly though it could start on one side. Guillain-Barré syndrome is something people wouldn't often think about, but about 50% of patients with Guillain-Barré syndrome have cranial nerve palsies. The cranial nerves, aside from 1 and 2, are peripheral nerves, so they can be affected in Guillain-Barré. Sarcoidosis, people will laugh, isn't sarcoid just on the differential for everything? Sort of, but when sarcoid affects the nervous system, the most common thing it does is cause a cranial nerve palsy, and the most common one is cranial nerve 7. So not that we go hunting for sarcoid in every case, but in a facial palsy that we thought was idiopathic that didn't get better, maybe some other clues towards sarcoid, you might think about it. I think those are some of the main things. Traumatic would be another possibility. If the nerve gets damaged, passes right through the parotid gland, and so right around here, facial trauma or skull-based trauma could damage it. Okay, I think we've talked a lot about all the different ways that the face could become weak and things on the differential. And so let's hear a little more history from Gabby, and then see where we are.
Awesome. So the patient is a woman. She's in her 40s. And she said that she went to sleep in the day before around 11 p.m. And today she presents to the emergency room with difficulties moving the right side of her face. She denies any fever, weight loss, or any other neurological symptom associated with this episode. But she had 2 previous episodes like that. One when she was an adolescent, and one 4 years ago. And all of them were a complete facial palsy of the right side, and she had a complete recovery. About the social history, she's a smoker. Previous medical history, she also has hypertension, and she had a C-section 12 years ago. And she uses losartan 50 milligrams a day for hypertension, and no other medications.
Great. Interesting twist, Gabby, as always. Thank you. I think you went first last time, Sarah. So Saki, I'll ask you what comes to mind now that you have more history.
I think when she said that she was a woman and she's had recurrent episode, the first thing I thought of was recurrent, maybe TIA. But then the moment she said that it gets that she had the first episode when she was a child, and then one 3 years ago, and then now again, TIA I think went slightly lower on the list, and it was looking more like an infectious, idiopathic kind of a process that kind of recurs and gets better. And I would want to know if she got treatment in her previous episodes and that's how it got better, because I don't know whether it just gets better on its own. I don't know about that. That's something that I would want to know. And yeah, and she said complete facial palsy, so I think she means lower motor neuron now. So we know for a fact that it's lower motor neuron, which is why idiopathic versus infectious versus all the sarcoid and all the thing autoimmune. These are the things that are kind of coming to my mind.
Great. Yeah, I was also very struck that this is recurrent, right? We were all thinking this is a one-time thing that's happening, maybe for the first time in isolation, and then what is it? Is it central or peripheral? But now we're hearing about a recurrent facial palsy. We don't know yet until we examine the patient whether it's going to be central or peripheral. And actually, in patients who've had a history of seventh nerve palsy, it can get very tricky to examine them because as the seventh nerve recovers, there can be some aberrant regeneration. You can get what's called synkinesis of some of the functions. Remember that facial nerve, Sarah, since you're studying for step 1, has the 5 branches: to Zanzibar, bimotor carotid, temporal mandibular, to Zanzibar, temporal zygomatic, to Zanzibar, buccal, mandibular, cervical, right? So I obviously don't use those on a daily basis, but you might use them on step 1. So I mentioned them, but it has these branches, and when it regrows, some of them go to the wrong place. So the patient, when they smile, might wink, when they wink, might smile, when they tear, might salivate, when they eat, might tear, because the salivary and lacrimal glands are done by 7, except the parotid, which is done by 9. So, so the face can also get a little bit of sort of spasticity, not spasticity isn't the right word, sort of can get a little bit of contracture from being weak. And so sometimes a patient with remote Bell palsy, it's very hard to tell which side the patient might not remember, was it left or right? And they looked in the mirror, they see pictures, right? Our sense of our left and our right, if you're not a neurologist or a yoga teacher, exercise teacher, always doing things left or right, backward from the patient, or looking at chest x-rays, right? The patient may not remember, and you look at the face and say, well, this one actually looks stronger, but it's actually contracture. So this could be a confusing exam to tease apart. But yeah, recurrent, you mentioned TIA. Whenever we hear about transient episodes in neurology, people think of TIA. It'd be pretty uncommon to just get facial weakness as the only manifestation of a vascular syndrome. One of my mentors asked once, has anyone ever seen a stroke that caused only facial weakness, nothing else? Nobody said that they had. It doesn't mean it's impossible, but the face and arm areas are right next to each other. You'd really have to have the world's tiniest stroke in the face area of the homunculus to get just that. Is there not going to be some speech problem? Is there not going to be a pronator drift? And even if we said maybe this patient had face and arm and they don't remember the arm and was it a TIA, to have the same TIA over and over again would be a little atypical also, right? It's possible if you have a distal stenosis, if you have a stenosis of the middle cerebral artery and you keep getting little hypotensive events distal to that, or little artery to artery embolism, you could get the same stereotype TIA. Vertebral basilar, sometimes you get the same stereotype TIA, but usually if the TIA is coming from the carotid or the heart, each time it could go to a different place, right? So what are the chances that you flip the coin and you get MCA every time you flip and you get the same branch of the MCA? And she's only 40. You can have a stroke from in utero to the last day of life in older age, but gee, if someone thought one of these was a stroke or a TI in the past, probably we would know more, though not necessary. But if it was really just facial weakness each time, and it sounds like it lasted a long time and recovered, it sounds a little less likely, as you concluded, Seki, for TIA, but just to unpack that a little bit. So probably not recurrent central, but we'll see on the exam. So if we have a recurrent self-resolving facial nerve palsy, is that a pattern? So you can get recurrent bell palsy. It's common enough that you could get it once and you could get it again. On the same side, I guess you could, 50-50 chance, right? Anything else that causes recurrent facial palsy? Sarah or Saki, any ideas?
I'm not sure if this can, I'm not sure, but there is a virus, varicella virus can also lead to a syndrome. It's like Ramsay or something. I don't remember the name, but generally, like, since it's not fully, like, you cannot get fully cured, like you can keep having it again, but generally it's accompanied by another symptoms like hearing loss and like infections in your ear, like rash in your ear. So since she doesn't have like any symptoms like that, I doubt that this might be the case, but I know it's something that can cause reoccurrence.
Yeah, great thought. So Ramsay-Hunt syndrome, very uncommon. Maybe I've seen 1 or 2 cases. Usually affects the 8th nerve and the 7th nerve together. So people say if you see what you think is Bell palsy, you should look in the ear and see if there are vesicles. The 7th nerve does so many things aside from the face. We talked about lacrimal, salivation, taste of the air, anterior 2/3 of the tongue, the stapedius muscle, and it also does a little patch of skin behind the ear. For some reason, 7, 9, 10, they all do little patches of skin. And so you can actually see zoster vesicles in the ear. These patients can also present with vertigo or hearing loss if the 8th nerve is affected. I remember a very striking case as a resident. The patient had Bell palsy and a co-resident had shown me the picture that the patient opened their mouth and it was just perfectly split the midline, vesicles on one side of the palate and not the other. So it can be very striking that VZV really shows you that these dermatomes are real, right? There's not just some drawings in a book to make medical students have to study harder. And VZV, when it breaks out in shingles or in zoster eruptions, can respect these dermatomes to the line. Whether Ramsay-Hunt can recur, to be honest, I'm not sure. It's so uncommon. If you get it once, are you likely to have it again? I'm actually not sure on that, but it's great that you mention that for other STEP studiers because it's an important pattern recognition and a reminder that 7 and 8 can be affected together because they both pass along the cerebellopontine angle and through the internal auditory canal. So 7 and 8 can be sort of a pair. We only have one cranial neuropathy so far, so I won't go down the rabbit hole of multiple cranial neuropathies, but some are associated because their nuclei are close in the brainstem. If we saw 6 and 7 together, we'd know we're in the dorsal pons. Some are associated by their path through the skull base, and 7 and 8 both pass through the internal auditory canal. So a vestibular schwannoma affecting cranial nerve 8, causing unilateral hearing loss tinnitus, can also cause spatial weakness for that reason. Okay, Saki, were you gonna throw something else out there for recurrent facial palsy?
Yeah, I think recurrent facial palsy for a lady comes and goes. I would think of MS or any demyelinating lesion, I think, that has been remitting and resolving. But I don't know if you can only get facial palsy and nothing else, because like you said, it would have to be a very tiny focus and then nothing else. But I haven't seen just MS with a facial palsy, so don't know about that. That's it, I think.
Yeah, good thought. So MS is a central demyelinating disease, right? So if we had a demyelinating plaque in the subcortical white matter, or if you had a demyelinating plaque, I've never seen this, though it's theoretically possible, in the fascicle of the cranial nerve, which is the name for the cranial nerve when it's still in the brainstem. It's not the nucleus anymore, it's the axons, but it hasn't left the brainstem. It's called the fascicle. In principle, I guess a lesion there could even cause a lower 7th nerve palsy. I've never seen that, but presumably possible. Yeah, whenever we hear relapsing, remitting, right, we should think about MS. Pretty atypical for MS to just cause the same thing again and again and again, right? And for it just to be facial weakness if there's been multiple attacks. If the patient had one attack that caused facial weakness and there's a scar of demyelinating plaque and it gets worse with heat or exercise, the Uthoff phenomena, maybe that could be a way of thinking about it. The patient had an original stroke, caused the central facial palsy. And then when they get a medical illness, it's called recrudescence. Sometimes the stroke symptoms sort of come back. It's not a new stroke. It's just that area of brain is not functioning normally and can sort of, just like whenever any of us get sick, right, our whole sort of brain feels like it's not working as well, right? If there's one area that's damaged, then that area will work even less well than the surrounding normal brain. We don't know how recrudescence works, but it's a thing we see. The only other thing I'll put out there, and this is super rare gourmet neurology, and is Melkerson-Rosenthal syndrome. That will not be on step 1. It's a recurrent facial palsy, recurrent facial edema, and a fissured tongue or something. This is one of these just super rare things. I can't really think of another thing with recurrent facial palsy as the only symptom. Unless, again, we learned that it wasn't really recurrent, that it's progressive, or that it's sort of, they thought it was getting better, but it wasn't. And it's actually just one continuous worsening 7th nerve palsy on one side. And then is there some slowly growing mass? Maybe like a vestibular schwannoma or something on the skull base pushing on just 7 without 8 would be hard to say, but maybe there's some unilateral hearing loss that the patient didn't notice. And that might change things. So I'm not sure, recurrent facial palsy. The only thing that came to my mind, aside from all the ways we tried to make this into other things, is Melkerson. I think it's Melkerson-Rosenthal syndrome that causes this odd constellation of symptoms. Recurrent facial palsy, I think recurrent facial swelling, and then what's called a geographic tongue, where the tongue is very fissured and has lots of lines on it. Okay. No idea. Gabby, tell us the exam. Was there a fissured tongue?
So I will start with this description of the facial palsy. So she had a facial palsy in the right side, affecting both the upper and lower face. We tested some things in the facial palsy. So we told her a joke, and when she left, the palsy was still present, the facial weakness, and also she didn't have the palatal reflex bilaterally. Otoscopy, we couldn't see any vesicles or rash on the ear, and she also had upper lip edema. And I'm gonna show you the picture of her tongue.
Oh wow! I've never seen this in. This will be the closest to real life. While you're pulling that up, let's just, oh, here it is. Well, let's take a look at it. That's it.
So this is her tongue.
Oh my goodness. Gabby, every case you present, you need to publish. This could be a New England Journal image. You don't see this one every day, not even every Tuesday. Okay, go ahead.
Sorry, I just wanted to add that I was reading, and the fissured tongue is actually present in like less than 1/3 of people. So it can be common, but when associated with the palsy, we have to think about. So if you see only the tongue, you don't have to think about the syndrome, because this can be not. I just wanted to point that out.
Some people have idiopathic, geographic tongue. Okay, well, let's jump back a second, because you told us some beautiful neurologist pearls there, and how you explained some of the things that were present and not present on the exam before giving us the wow moment of the tongue. My goodness. Okay, you told us, hold on. You told us that it's the upper and lower face on the right side. So Sarah, if it's the upper and lower face, where is the lesion here? Oops, you might be muted, I think.
Then it's in both nerves.
Yeah, so it means it's in the facial nerve, right? If it's the upper and lower face, so this patient's not closing the eye on that side, the patient's not smiling on that side, it's the 7th nerve somewhere along its trajectory. Very good. And why did Gabby tell us that she told the patient a joke and it didn't change? Then either of you know why that is? I'd like to know what the joke is also, but does anyone know why you might do that? It's less relevant in the peripheral palsy, but if a patient has central facial weakness from a problem in the motor regions involving the face, the emotional pathways for motor activation of the face actually travel in a different pathway. So if you tell the patient, smile, they smile on one side, nothing happens on the other side. Now, usually these are patients with stroke, so it doesn't necessarily feel that comfortable to tell them a joke. But if in the course of the conversation, they observe something funny or their family says something funny, you may actually see a symmetric smile. It's one of these amazing sort of neurology things. And the limbic pathways, or I actually don't know the exact pathway, also innervate the muscles of facial expression. And we know the basal ganglia have something to do with it, right? Because patients get a masked face in Parkinson's disease. So you can actually get dissociation of smile to command and spontaneous emotional smile, which can be very striking that same muscle will work perfectly in one context and not the other. And I believe there's a way to get the opposite. I've read, but haven't seen. And then Gabby is a true neurologist. She tested a palmomental reflex and said that was absent. Either of you know what the palmomental reflex is and when we usually use that?
Sarah, you wanna try?
Have you heard of this palmomental reflex, Sarah?
Yeah, oh my God, I did. Honestly, I have no idea how to explain this in English, but I have heard of this before. Some time ago, I was in neurology class, like it was a pediatric neurology class, but the teacher said something about it. And I do have like some notes in Portuguese, but I don't know how to explain it. I'm so sorry.
No problem. Do you want to explain it in Portuguese and Gabby will translate for us?
Oh.
You don't have to, but you can.
Oh,
You don't have to.
I don't know if I'm gonna say something crazy. I prefer Gabby to say something. It's
Okay, no problems. No worries. Just we all like learning from each other's languages. Saki, do you want to explain what this palmomental reflex is and why Gabby was why I was impressed that Gabby checked it in this context?
Yeah. Unclear about the second question, I'll try, but the first question about what it is, I can tell you. I think if you stroke the palm over here, it's kind of a frontal release sign. So when you stroke the palm here, there's a slight a twitch on the chin that you can see in the patient, and it's basically, I think it's present in kids, in children, and it's present in people who have frontal and prefrontal cortex disinhibition. It means when those areas are affected. So I would expect it to be in a child or an old person with, say, dementia or something involving the frontal lobe. Why she checked it for a peripheral low facial nerve, I don't know, but I'm prepared to be blown away.
Right, so this is a reflex where you just sort of scratch the palm briskly and you might see a little twitch in the chin on the other side. This is categorized as one of the frontal release signs, along with the snout where you tap on the lips and the lips purse, the grasp where you put your fingers in the hand and the patient grabs on, the rooting where you rub the patient's face and they look over to that side, the suck where anything, sometimes even if you approach the mouth, the patient will go to suck on it. These are from frontal lobe pathology, which can be seen in dementia, can be seen in just advanced age, can be seen with prior head trauma. I was reading De Jong recently. Anyone in neurology or who is going into neurology, that is an amazing book with levels of, one of my colleagues called it molecular bedside diagnostics, like the incredible details. And I was actually just reading the other day, it's my daily vitamins, reading a little bit of this book each day and trying to learn new things. But that one, the palmomental is actually pretty common in normal individuals as well. So if you do it on someone and they have, this doesn't mean they have dementia. The book, Valeria, is De Jong, yeah. think it's just called the neurologic exam or something. It's like an 800-page book on the exam, and it is a beauty. So yeah, it can be present normally. So, and it can be asymmetric. And for me, it's just one of those sort of bedside rounding things in a patient who clearly has frontal dysfunction. You can show it, but I don't always go looking for it. But Gabby must have read this book because he mentioned that in a peripheral facial palsy, you will lose the palmomental on that side. Again, there are more sort of obvious clues, but it made me think the next time I see this, I want to check and see if it's asymmetric. But I found it's actually not that common to elicit even in patients who you would expect to have it, compared to a grasp, a snout, which seems to be more common. But Gabby must have read this section in De Jong and been curious to the next time she saw a facial palsy to look and see if the palmomental was out. And the emotional smile here, again, doesn't matter what the brain can do, unilateral, bilateral, subcortical, cortical. If the nerve can't transmit it to the muscles of the face can't move, right? So just in sometimes an early Bell palsy or early seventh nerve palsy, because of those 5 branches, you can get fooled because the facial palsy is not complete at onset. I remember one of my residents was paged for an acute stroke in a postpartum woman who woke up and saw that her face was weak, and he came back and he said, I think it's a stroke, and she doesn't know when it started, so we can't give TPA. And then when we went, she said it's just the lower face. When we went to see her, it was a super obvious Bell palsy, and some of the residents were teasing the resident, and he said, no, I swear, when I was here, it was just the lower face, and it didn't look like it does now. The upper face is so involved. And I said, no, this happens, right? Where sometimes the facial palsy evolves, and you see the lower face, and you think, uh-oh, could this be central? You get the MRI, and by the time they come back, you say, it's Bell palsy, or you admit the patient in the morning, everyone says, why'd you admit this patient for Bell palsy? And you say, no, it looked like a central palsy last night. And those are things where, some of these reflexes may or may not help you. Okay, well, I think with that tongue, it's an early ending today because there's no tests you would get. So tell us, Gabby, what, do you give steroids for an acute attack? I've just seen this in books, and it's one of those things that you never see in real life. Sometimes you read something, right? And because you've seen it, you realize, oh, I've seen that. Or because, like reading De Jong, I've never tried testing that sign. I'll do it next time. And then you remember. And some things you remember just because they're so striking, right? Recurrent facial palsy, facial edema, and a geographic tongue, and a striking name, Melkerson Rosenthal, and you just remember it for no good reason until today. So Gabby, tell us how you and your colleagues made this diagnosis, and whether there's a family history. Did you treat it? What did you learn in looking this up? Because I know everything I know about it, I told you, or tell me that I'm wrong and it's something else. Maybe I got too excited about this thing that I read about and never saw.
Yeah, our diagnosis was Melkerson Rosenthal syndrome. This woman, she didn't have any other family history, but it's common in this syndrome, and it's not completely understood. Usually it is associated with some infiltrations showing inflammation if you do a biopsy in the upper lip, for example, but the person can have like edema in the whole face. And this woman specifically, she had only upper lip edema. We didn't treat her, and I don't know because we lost, I don't know how she recovered, but probably she recovered, but I couldn't see her again, unfortunately. Yeah, so and other thing that I wanted to share was that the palmomental reflex was, when I was in the first year of residency, I was reading De Jong, and I read about this reflex, and the thing that I did was I tested it in myself, and I have this reflex only in my right side. So for a couple of days, I was reading about this reflex many times because I wanted to know if this could be normal. So as Aaron said, I just wanted to explain that everything in neurology, we always value symmetry and asymmetry, but also the whole context is important. For example, if this person had a palmomental reflex in the left side and didn't have in the right side, we would value it. So this is something that I wanted to share, but I think you don't need to treat, but it's been a long time since I don't study about this topic. And unfortunately, I don't know if she recovered, but I think she did, as the disease is expected to recover.
And when you saw her, Gabby, she had a full facial palsy on the right. Did she have any of the evidence of prior facial palsy, synkinesis, or any of those sort of facial nerve recovery signs?
I don't think I noticed that, but at that time I didn't know that exists. So I don't know if she didn't have or if I didn't notice, but it was not something very obvious, no.
Got it.
Mhm.
Okay, well, what a case. You saw it here first, probably last, and probably never again. And so if you, good lessons from Gabriella, if you see a geographic tongue, it's not necessarily abnormal. If you start checking the palmomental on all your patients, and some of them have it and some of them don't, if you check it out yourself, it's okay. I forget the number in Dejong, but I was something, don't quote me, but 15, 20, 30, some large percent of people, at least according to this very incredible person who can write 800 pages on the neurologic exam, probably seen 1 million patients, has found that it can be fine. I think Gabby has shown us, based on her discussion, that it is not relevant in her case. Okay. Wow, so cool. Valeria, you want to tell us some teaching points for today?
Yeah, this case was amazing. Thank you so much, Gabby. So we started with the chief concern, which was facial weakness. And so as everything in neurology, we have to consider the location and the time course to think about the etiology. And so with facial weakness, we can divide it into central, thinking about cortical lesions, in which case we'll expect that the upper side of the face works fine because there's contralateral cortical compensation. Whereas in peripheral damage of the nerve, we will have hemifacial palsy. And then with time course, Saki pointed out that this could be, for example, in a stroke that's causing central facial weakness, or something like an infection, or something more subacute chronic, like a demyelinating disease, inflammation, like we were thinking about sarcoidosis, and also malignancy. And then some pearls that I picked up was that from Aaron, that in peripheral palsy, we shouldn't expect ptosis, but the lack of the ability to close the eye on purpose and the absence of blinking. And so even though it is an hemifacial palsy, we even can expect that the eye can be more open than the contralateral side. And then with recurrent Bell's palsy, I pulled a paper and they mentioned that it recurs in 4 to 7% of the cases. And some risk factors or some associations that are not very clear are malignant hypertension, diabetes, and pregnancy. And unilateral recurrences require evaluation to rule out malignancy, particularly schwannoma. And then also another possibility is this syndrome called Makkerson-Rosenthal syndrome, in which it's a triad of recurrent facial swelling, it's particularly upper lip swelling, facial paralysis, and fissure tongue. And it's part of the orofacial granulomatosis complex that there's a lot of syndromes and is usually associated with a higher risk of Crohn's disease, but has a very broad differential and usually starts in adolescence, like in this case. And the treatment can include the steroids or nerve compression and some cosmetic options as well. And then some final pearls was that the spontaneous smile in central facial palsy can be explained because there's another pathway that is, there's an emotional response to, for example, a joke. And so you will have a spontaneous smile because the nerve can conduct that part of the cortex. But if the nerve is damaged as peripheral palsy, then you cannot have that spontaneous smile. And then finally, in peripheral facial nerve palsy, the palmomental reflex is lost. So thank you so much, Gabby. This was really amazing.
Yeah, amazing case, Gabby. Thanks for bringing this to us. Sarah and Saki, great discussion. And Hamza, we haven't forgotten about you for next time. Would be great to have you next Tuesday. Valeria, fantastic teaching points. And I think this is the first Neuro VMR we've ever ended early. So since there's time, Gabby, we all want to know, what was the joke you and your team used to see if the patient has a spontaneous smile?
I don't remember, but it was before COVID, so it was easy to say something a little bit funny and the person would laugh, because now you have to ask the person to remove the mask and it's less natural, but I don't remember the joke. Sorry.
Okay, that's okay. We are looking forward to a good joke to end. Well, thank you so much, everyone. It's great to be back. We will be back next Tuesday. So if you have a neurology case you'd like to present, if you feel like you have one sort of, but want a little help on it, Valeria, Gabby, Maria, our team neuro is happy to help you make sure it's ready to go. And then maybe you'd like to discuss next week. Look how much fun we had with Sarah and Saki this week. So thank you very much, everyone. Have a great rest of your day or evening, and we'll see you next Tuesday.